Good afternoon. Welcome to staff around the country to this staff webinar. We're joined by the Chief Executive, Paul Reid, the Chief Operations Officer, Anne O'Connor, Chief Clinical Officer, Dr. Colm Henry, and Dr. Linda Sisson, the Head of the Workplace Health and Wellbeing Unit here in the HSE. We're going to take questions from people. If people have questions, we've a good number in already, but please email to internalcomms@hse.ie. We have about an hour, so hopefully we'll get through as many questions as we possibly can. And first, perhaps to ask Paul a question. There's a lot of comment, a lot of discussion on how to acknowledge the staff in the health service and how to acknowledge staff generally who have gone above and beyond over the past 18 months or so to keep people safe and keep society going. What are your thoughts on that? What are your thoughts on all the talk and conversation about acknowledging staff and how to do that?
Yeah, well, firstly, Mark, I've been on the public record of setting out our appreciation from the HSE in terms of our own staff, the sacrifices that they made, and not just the sacrifice that they made themselves, but the sacrifices that their families made. And I'll always recall when you go back to, particularly back to March in 2020, when the whole public were scared. We were all scared, and no doubt our staff were scared, but they went out in the front line practically, put themselves at risk and, as I say, made many sacrifices. I do think we have to find a way and a mechanism to recognise this. And I know politically many people have said it, that the appreciation is there. It is a difficult one, it's a complex one, because as you can see, the debate moves on to many different parts of many different sectors of society that feel, and in reasonable cases, they made sacrifices. I do think a way will be found through this. Obviously, it's not completely in the remit of the HSE and ourselves, the executive, to resolve this one, because it is a whole of government issue and whole of government policy. But what I can say is, I do believe there's a genuine intent from what my engagements have been at a government level to come to some resolution on this one in a way that, I suppose, unifies society rather than divides society. That seeks to recognise the public contribution, our staff's contribution, and sacrifices that many people made. So in summary, I think we have to give this a little bit more time. It is in the hands of government, but I do once again want to express my huge appreciation for the many sacrifices that our staff and families have made.
Okay, thanks very much. And maybe a question for Anne O'Connor. Looking forward into the coming months, I mean, we have been through an extraordinary time. How do you see the coming few months in the health service? There's a lot of talk, a lot of concern talk about how serious things are going to be, that the winter is going to bring a whole new set of challenges to the health service, coming on top of the very difficult period we have been through. What do you think it's going to be like?
I think it's probably going to be very challenging, if I'm honest. I know that across all of our services at the minute, we're seeing a lot of activity. So if you look from a hospital perspective, our emergency departments are very busy, huge demand, and whether that's people coming forward, having not come forward in the last 18 months or so, or just the change in population or whatever, it doesn't really matter. We are very busy. So I think people, as you said, Mark, are tired. We've been through a lot in 18 months. But we are heading towards winter, and that brings its own set of challenges regardless of COVID. However, we have lots of plans in place in terms of our winter plan that's been submitted to the department, and we are looking at how we can support services to do what they need to do. I think even, look at community services, there are some very real challenges facing staff and services in terms of just being able to recruit the right people, whether you're kind of a health professional within a hospital setting, within a community setting. We're very challenged on home support workers, and all of those, I suppose, issues will have an impact on how we can deliver our services. However, we have recruited a lot of people in the last year, and it's important that we continue now to work in an integrated way to deliver services. But I think it is fair to say that it is going to be challenging. It's potentially going to really require a very integrated solution in terms of supporting people to stay at home, reduce attendances, etc. But we know a lot about that from previous winters, and we'll just continue doing that. But again, just, I suppose, to acknowledge that people have worked incredibly hard over the last 18 months, and it's not like we can just shut up shop now and go home for a few weeks. We have to maintain our services at what is often the most challenging time of year for us, and the level of activity that we're seeing now would be akin to, I suppose, the depths of winter in previous years. So I think it will be challenging, there's no doubt about it.
And Colin, in relation to that, there's one very practical question coming in from quite a number of staff for yourself. There's a lot of talk of booster doses of vaccine, additional doses. Can staff expect that over the coming period of time, there will be a suggestion that staff get additional booster doses of vaccine?
Well, first of all, to assure that the vaccine, those who are fully vaccinated, just to acknowledge everybody who turned up to get vaccinated, it protects you, your family, and your patients, and ultimately the services as well. But that flood wall of defence is holding very tight. The protection it gives you against serious illness, against hospitalisation, admission to ITU, and against the most serious elements of COVID disease, it remains very strong. Yes, there are some studies showing waning immunity. For this purpose, NIAC have decided to advise a booster regime for older people for whom immunity seems to wane rather rapidly. And that includes, as people will know from the launch this week, of those aged over 65 years of age in long-term residential care facilities and those aged over 80 years of age in the community. But as I said, for the rest of us, the protection from severe illness remains strong. We know, for example, looking at a snapshot of ITU admissions, about 69% of those admitted to ITU in recent times unvaccinated. And if you go back over since 1st of April to October, looking at the entirety of people admitted to ITU, about 21% are what we would call breakthrough infection. They're predominantly people with underlying illness or older age. We're also tracking very closely those people, healthcare workers in acute settings. We have done working with Martin Cormican and an AMREIT program from the beginning. And this reached a terrible peak of about 1,000 cases per day of healthcare workers, 1,000 per week, I should say, of healthcare workers in January who got COVID-19 in the workplace. And now the figure is somewhat oscillating between 70 and 90 in recent weeks. Peaked over 100 a few weeks ago. So again, evidence that the vaccines that healthcare workers were prioritised with in those first few months of 2021 is holding tight. However, NIAC are constantly reviewing advice. We're in touch with them very regularly. At this point in time, I don't see them extending beyond those older groups for at least a month or so. But when they give us advice with extending booster regimes based on the evidence that's evolving, we'll be quick to provide access to all healthcare workers for a booster dose. But at this point in time, the advice from NIAC is it's not necessary. The protection you have is robust, and it protects you from serious illness.
And Linda, we'll come back to you later with some very specific questions in the areas of health and well-being. But if you were to give, I suppose, staff one piece of advice about how to manage their lives, how to manage their work lives over the coming period, what would it be?
Thank you, Mark. I think my take-home message for staff today will be access the services and use the services that are available to you. So I thought it might be helpful maybe just to do a quick summary of the services that are available. So most people are familiar with occupational health, which is the medical specialty that advises people on how to manage health issues at work. So there are 16 occupational health services around the country, and you should be able to access one very close to where you are living and working. Occupational health, of course, will be the go-to place if you have an underlying medical condition, if you have a concern about your health or concern about your work and your health. Also, if you are currently cocooning and you want further advice about whether or not you can get back to work. And of course, we are still doing pregnancy risk assessments for those who are working in the organisation. So that would be where I would go for the first point of contact. We are also very conscious that 18,000 workers in our public healthcare system became infected with COVID, and of those, many are still experiencing some residual symptoms as a result of COVID infection. So we are aligning ourselves with the model of care for long COVID. We are providing physiotherapy and additional and enhanced supports in occupational therapy for staff, and we'll be looking at assisting staff in managing their condition. In addition, we will have some phased return to work programs so that staff can get back to work earlier and that staff can eventually come back to work in their full capacity. You'll also probably be very familiar with our EAP services. We have a mixed model of internal and external services for EAP. We've over 400 counsellors with our current contract with our external model, and they're available 24/7. And this is, of course, a free and confidential service. We also have a number of internal counsellors who will provide services and individuals with face-to-face counselling, and they're particularly interested in working with staff who have had a particular impact on COVID on their mental health. So that is also available to you locally. One of the challenges that we came across during the pandemic were teams that were particularly dealing with complex psychosocial issues or working in very challenging environments. So we've built up the service called Organizational Health, where a team will go into with a manager and an extended team and look at the complex psychosocial problems that people have been encountering, and maybe put together an action plan, an intervention plan, and an implementation plan to assist the team in trying to be the best that they can, especially coming into the hard times in the winter. The stalwarts throughout the pandemic have been our health and safety team. They set up a helpline, and we had over 33,000 calls from healthcare workers, and that continues to this day. And they've also put in place a number of COVID-19 specific policies and provided infographics about staff managing fatigue, managing stress, managing shift work, etc. There is some updated information on return to work that should be launched this week. So if you are returning to work, if you are working remotely, or if you're working in a hybrid, please check out the website because there will be updates in that regard. So finally, just to say, in terms of the pandemic, what have we learned? I think what we've learned is that there was an acceleration of a need for enhanced supports. There was definitely a need to provide services to staff across a number of different platforms, which is why we're using many, many more online platforms for staff. We've set up a healthy workplace framework with Healthy Ireland. We're looking at a model that will focus on the entire employee experience. And we know that operations are picking up on that model and are now using that model to look at what staff needs locally. We know there's a programme just set up in Cork and Kerry and one in North Dublin very recently, and we will support you in that regard. So when we deal with the local operations, we'll be able to find out what are the specific psychosocial, the specific physical or personal health needs that your team or your area need, and we will support you on that. Thank you.
Thank you very much. As I say, we do have a number of questions in the health and wellbeing area, and broader questions about working in the HSE as we return to offices. But maybe we look at one of the big political issues first that people have been talking about for the last 2 weeks. A lot of coverage about Sláinte care, a lot of commentary saying that within the health system there's a reluctance to change, a reluctance to reform, and all of that. Paul, I wonder, can you give us an update as to where we stand at the moment in terms of health reform in general and Sláinte care in particular?
Yeah, I think it's been unfortunate that the resignations have happened for Laura McGahey and Professor Tom Keane. But that being said, we all have to move on and implement, all the people I talk to in the health service are really anxious to continue the reforms, embed many of the reforms that we put in place during COVID. And there's a huge appetite in the health service for reform. And that goes from the people who work in the frontline activity, the people who are in support activities, all the way through our services and straight to the centre of the HSE. So I think reality of it is now for us, first of all, we should all remain very confident that what we implemented and what you implemented during COVID were all major elements of reform. I won't go through them all, but in simple terms, moving that model of care closer to the community, putting in place new pathways that people didn't have to go to the emergency department for their care, putting enhanced supports with our GPs for GPs' access to diagnostics, increasing our capacity in the health system, in the acute hospital system, increasing our capacity in terms of step-down beds, a whole very different role for the National Ambulance Service, not just being 24-hour service paramedics, but helping to keep people at home. The supports we put around nursing homes, all of those are major elements of Sláinte care. I guess to cut to the chase, the 2 or 3 big areas that we do now need to tackle, and timing is never great, but having come through 18 months of COVID, I'd say there's probably a few priorities. First of all, let's seek to embed many of those reforms that we put in place and people put in place at pace. And I want to thank everybody for how you implemented those reforms. They were on PowerPoint, they were in Excel spreadsheets, you put them into practice. So first of all, let's embed those. Secondly, the two big, strategic issues we have, first of all, relates to our waiting lists. And many of you and all of you work directly in health services. We want to put in place a whole new set of actions in the short term and the medium term that sets about addressing waiting lists. We expect later this week the Minister to announce some plans in the short term about addressing waiting lists and extra capacity, and also on a multi-annual basis in a more longer term. And finally, in terms of regionalisation, we all know that devolving decision-making down at a local level, increasing integration between the acute hospital services and the community hospital services is a key way that we need to go. So in terms of regionalisation, we are working very closely with the department now about how we look at regionalisation in a very practical and pragmatic way to give that development, to give that level of integration down at a local level. So I think on the big strategic issues now is where we need to turn our attention. But let's not forget what we've implemented over the past 18 months is great credit to the system. And finally, that has all given great public trust and confidence to the public, to our patients about the health services capacity to implement reform. So we should take great confidence.
Okay, thanks very much. And Anne, obviously the challenge of dealing with the waiting lists falls very substantially on the operational system. Are there things we are doing this winter, or things you expect to be doing this winter in relation to waiting lists that we mightn't have done before? Or what can we expect in terms of services, in terms of that plan we're going to see later in the week, perhaps of short-term measures to deal with waiting lists? Can you give us a sense of what we might expect?
Yeah, I think so. To answer your question, are the things that we wouldn't have done before? Not really, is the answer. I think that we have done we've done all of these things in some way or another. So any of you dealing with waiting lists across acute or community services will be well used to validating waiting lists, looking to see who really is there now in need of services, looking at how we prioritise access to services. And I think maybe what's different this time around is there's actually significant funding behind it. So we have, I suppose, many times in the past looked at validating waiting lists, but we haven't always been able to invest in the solutions in the same way that we can now. And I think, looking at our capacity internally and externally is going to be key here. So the first step for us is to look and see, as I said, to look at those lists and see who's on them, break them down by specialty, by service area, etc. In the beginning, it's going to be very focused on acute hospitals, but moving on then more to community services as well. And I think that, for us, capacity is often a challenge. So how we can actually really look at the capacity that's really available to us, or that we can buy, as I said, from internal or external sources. And that really is the focus for us. And I think, that is the big difference. So really, this is a plan that galvanizes all the key people. So between ourselves, the department, the NTPF, and again, many of you who've been around waiting lists will be used to that. But really then being able to invest in a targeted response. So as Paul and Mark have said, there's a short-term piece to it, and then there's the longer term piece, in terms of longer term investment and capacity. But I think, it's a very good opportunity for us. We know that our waiting lists have grown. We had big waiting lists pre-COVID, and COVID and the cyber attack have made those worse. And whilst sites have been working really hard to try and reduce that, and again, mindful of the pressures in sites. So we're not doing this in isolation from all of the other discussions. So we know that the system is pressured and that unscheduled care plays a huge part in this too. But we really have to look at how we can have a coordinated, funded response to addressing some of those really significant lists that none of us want to have. And I think that's probably what's different.
And Colin, we've seen some questions coming in from different perspectives on the issue of social distancing, mask wearing, public health guidelines. Some people asking, when are we likely to see further relaxation or complete relaxation of these, as if they are looking forward to that, as in many cases, obviously we are. On the other hand, people who work in clinical environments expressing concern, saying, are we going to see a relaxation of social distancing, mask wearing, and so on, in a way that might be premature? How do you see that going? I know these are ultimately not decisions for us, but how do you see that going over the next few months in terms of those guidelines?
We're dealing with a moving target here. On the positive side, we're dealing with highly vaccinated population, astonishing levels of uptake among healthcare workers, among the population in general, now approaching nearly 92% of over 18s fully vaccinated. And that gives us all much greater protection. Certainly, because of the degree of protection that affords us as a whole people, it creates choices. And the choices include the kind of scenarios that are played out in some of these questions. What happens at ordinary meetings, not clinical meetings, but meetings where people meet outside the judiciary, people making at work, all kinds of settings. What kind of rule sets should apply there? And that's something that's under constant active review. And we do that with our own infection prevention control teams, Martin Cormican, led by Martin Cormican for our own staff. But in clinical settings, I don't see any easing off on those basic measures which have protected us from the very beginning. The mask wearing, the distancing, the hand washing, all those measures we know reduce transmission, particularly of this Delta variant, which is perhaps several times more transmissible than the original wild variant we had a year ago. And it's important to remember that although what we know about the vaccine, as I said earlier, it protects us from serious illness, from hospitalization, ITU, and death. It doesn't necessarily stop people contracting the virus in the first place, and it doesn't necessarily reduce to the same extent people transmitting the virus on. And if I could just quote one study, Mark, in Scotland, fairly early on in the vaccination program, they saw that family members of unvaccinated healthcare workers were much more likely to get COVID than family members of vaccinated healthcare workers, suggesting what we know now, which is that it may well reduce transmission too, but just doesn't abolish it. Because of the particular risks of healthcare settings, we're still obliged to use those basic protective measures that were there long before the vaccine program to prevent transmission of the virus within the workplace, where the effects could be particularly detrimental.
Linda, we have a few health and well-being questions in. We might as well ask you some of them first. And one which sounds like to one particular staff member, but I'm sure it echoes many. I am feeling very stressed, worn out with COVID. Where can I go for help? The whole COVID thing over the last long period has really affected me badly. I don't know where to turn.
I think if I would start with accessing the EAP services and start getting some personal supports through the EAP services. I think the next step would be to use our risk assessment policy for stress and to sit down with our manager and just go through some of those issues. If, however, the employee is feeling that they are unwell and they need to take a period of sick leave, they should discuss that with their GP and perhaps discuss it with an Occ Health physician. So I certainly think that employee needs to take some measures to try and address the stress, and there's some suggestions.
And somebody else here that's saying, I'm back at work now, but I'm not full time because of COVID. Okay, this is a very specific pay and conditions question. Actually, I'm not sure if anyone knows the answer off the top of their head. Can I get paid so long as I am working half time?
So the special leave with pay for COVID will continue even as you're returning to work over a period of time. So you can return to work on a part-time basis and supplement your pay with special leave with pay.
Okay, a number of questions coming in from people asking about pregnancy risk assessments. If I'm pregnant and I'm working in a role that puts me at some risk on contracting COVID-19, what do I need to do? I presume that's about pregnancy risk assessments and all that.
Absolutely. So as soon as you're prepared to tell your manager that you're pregnant, then you should be referred for an immediate assessment by Occ Health, preferably before 14 weeks. The Occ Health will then put you into a risk assessment process and will come up with very specific advice for you and your particular role.
Okay, and somebody here says there are several hundred staff who have been cocooning and taking particular precautions because they're more vulnerable than most to serious illness in the event of COVID-19 infection. As we begin to talk about returns to offices, how are those people affected?
So at the moment, Mark, we know we have about 600 people who are still cocooning, and I suspect that many of those people have underlying medical conditions, and some of them might be immunocompromised. So we are expecting that a large proportion of those people will get a third vaccine. So my advice to those people is once you get your third vaccine, please present yourself to Occupational Health for a further assessment, and we will be able to assess your response to the vaccine and make necessary arrangements following that.
Okay, someone here saying there are a number of wellbeing initiatives out there. How do I know which ones are the ones for me? How do I know whether they're any good? Is there anywhere we can go to find out what's the best thing we can do for health and wellbeing?
Well, I referred earlier to the Healthy Workplace Framework, and the only initiatives that we will have in the framework will be evidence-based. We have a number of key metrics as well, so we will be able to demonstrate that they're working for our healthcare workers in Ireland. So I would say go to the Healthy Workplace Framework.
And you refer to a number of services that are available. Where's the one central place people go to have a look for themselves?
So the WHWU, the Workplace Health and Wellbeing Unit, have a site on the HSE website, and we can certainly circulate it after this meeting today.
Okay, great, thank you. And a big question for very many people, it might be for Paul. It's about, what does hybrid working look like? There's a lot of talk about, as we return to work, we may not return to work in exactly the same way as we were doing 2 years ago. What might that look like? Do we have a sense of that?
Yeah, I think in the first instance, big policy issues for government beyond the health service, but for employment in general. What does it look like? What's supported? What's expected from the workplace? So there's policy issues that government have to work through. I guess from a HSE perspective, it will all depend on the role that you carry out, the area in which you carry that out, and the needs and expectations of the services. So first of all, we have to keep ourselves focused about the services that we're expected and the public fund us to deliver, and what people and what resources do we need at the workplace to ensure those services are delivered effectively and safely. So that's the kind of guiding parameter, looking at the services and the priorities of those. Within that, it will differ. It will differ between roles and locations and the roles that people carry out. And we will have certain central guidance based on policy issues from the HSE. But ultimately, as there was throughout COVID, there have to be assessments made at a local level about what's practical, what's reasonable, and what's needed from the service perspective. And I must say that there's mixed expectations from everybody in this. Some people want to get back to the workplace and really miss the workplace and want to be back at work, as many days as possible, 5 days if possible. And some people have got into a rhythm of working, effective rhythm of working, and work and life balance, and would prefer to have working at home. So there's many different views will come forward, but we have to be primarily focused on or guided by the services that we're aiming to deliver, and not necessarily what my preference might be. So there has to be our guiding parameters and make decisions around that. So we will give guidance and there'll be local decision making required as well.
Okay, thank you. There's a question here about the ongoing staff survey. I know there's a staff survey underway at the moment. Everybody's received emails about it. How will we respond to the feedback we get in the staff survey? I suppose that's a sense people complete a staff survey, they send it in, and they don't necessarily see where it goes next, if you like. How do we respond to that?
Yeah, look, briefly, I think first thing I would urge everybody is please complete the survey. It is really valuable information for us. It gives us some common themes that we have to address. It gives us some local issues that we have to address, but it gives us a real richness of information about where is the heartbeat of the organisation of our staff, having been through the 18 months, 20 months for us of COVID. What are the big issues that staff feel now? And indeed, Linda touched on some of the supports that's there, but getting beyond some of the supports, what are the big strategic issues for us from a people management perspective? So I think what it will do and what will happen next, when the survey results come through, we will be reviewing them with the executive management team. Each of the local services and management teams will be reviewing them from their perspective. And we will put in place plans to address some of the common themes that come through. And then equally at a local level, in expectation that local management teams would review them, discuss them with their teams. And I really would like to see that happen, that there's an engagement, a discussion between local team managers and team leaders and their teams about what their teams felt about the feedback and what's relevant for them in their local area or their service. So I think we'll do it at a national level, we'll do it at a regional level, and we do it at a local level in terms of some actions that arise from it.
Okay, thank you. Colm, I see a question there that's probably for you about the reinfection rate for COVID-19. That seems to be a vital element of planning for the future. What information do we have on this?
Well, we break it into two. First of all, pre-vaccination, we knew from pre-vaccination times that people could get reinfected. At the beginning, there were some isolated reports, but relatively small in number. And then that was at a time when we were still learning about the duration of immunity and the type of immunity people would have against COVID-19. In the vaccinated era, of course, as I said already, the vaccination affords great protection against serious illness and perhaps less, but nevertheless significant protection against minor illness. I alluded earlier to what we call breakthrough infections, which I suppose is aligned to this question. And we do see breakthrough infections and serious illness, albeit at a relatively small proportion, and albeit among people who perhaps have in those risk groups that we identified for an enhanced dose, people who are immunosuppressed, or in older groups who are now the target for booster vaccines. That isn't to say that other people can't get reinfected post-vaccination. It can happen, but thankfully much less so than happened in the pre-vaccination times.
Okay, thank you. And Anne, it's the first staff webinar we've had since the cyber attack in May. How do services stand? Are most services now back up and running as if it hadn't happened, or are many services still significantly impacted? Can you give us some update on that?
I'm not sure any of us could say anything as if it hadn't happened. I think, yeah, so in reality, most of our systems are back. And services are working again. There's a few residual, often localized systems that are still a challenge, but overall it's back. I think our challenge at the minute is more around data entry, so ensuring that the data that was captured manually during the cyber attack is now reconciled with, I suppose, our electronic systems. So I think that is the big task and the big challenge for services at the minute, and ensuring that that data, I suppose, is valid and accurate, because we know that that isn't straightforward in some sites. So I think, yes, services are back. You know, we know there are still problems. There are still issues being flagged with us in terms of some sites having very specific issues. And obviously where there are issues, that does impact significantly on those services. But overall, most of our systems are back. And as I said, really the focus, Mark, is just on making sure now that we're joining up the dots from really mid-May until, you know, early September when we got things back properly.
Yeah, can I just add a couple of comments to what Anne just said there? Firstly, to acknowledge and recognise the responsiveness and resilience of our staff during the cyber attack, because sometimes it gets lost. We talk about COVID. The cyber attack was quite catastrophic, and how patients' lives weren't lost through that process is primarily a function of the responsiveness of the services in the system. And I went around and visited some people during it, and it was just incredible, the workarounds that people put in place in a very short time frame. So thanks for that. There is a question just there briefly to mention, I saw coming through, about what corrective actions are we taking based on the cyber attack. And very briefly, there are a few. First of all, we didn't have 24/7 technology monitoring of our network. We did have people who did shift patterns, but we've put in place an arrangement now where we have 24/7 monitoring of the network. Secondly, there's a number of firewalls that needed to be enhanced to protect against access from cyber attacks, and they have been enhanced. Thirdly, we've replaced a lot of our legacy network and kit. We've over 2,000 servers across the country. We've over 20,000 systems. We've had to upgrade a lot of those as we were restoring them. And finally, there is a process which is ongoing, led by PwC at the moment, which is setting out a whole set of recommendations based on what happened in the cyber attack. And we will be bringing that to the board in the coming weeks, indeed to the Minister. And that will set out a whole suite of further recommendations and investment in resources that we expect to make.
Thank you. I see a very blunt but interesting waiting list question there. I mean, we're expecting an announcement from government later in the week for kind of a short-term plan for dealing with waiting lists for the remainder of the year. Someone is saying, are we throwing money at waiting lists? So is the government actually making significant changes to what we are doing to deal with waiting lists, or are we throwing money at waiting lists in a way that doesn't somehow fundamentally change where we are?
I think that comment, I was just reading it myself, I think it's a very valid comment. So the person is saying, you know, if you don't change what you're doing, you'll just go back and have the same issues, which is absolutely the case. So we know that a lot of our waiting list initiatives in the past have given us a short-term fix. So they've reduced the list, but in the absence of, I suppose, process improvement and all of that, we've just gone back to developing those lists again. So the work that we are, I suppose, that we're going to be doing now really does look at that process improvement as well in terms of how we're doing it. So we have to do both. We have to reduce the number of people on the list, and then we also have to look at how we're doing it differently. And I think what I'd say there is that, what is also different, just going back to the earlier question, is that we have a very different environment in terms of our primary care and community services. So in terms of that integrated care response, we haven't always had that. So having our, enhanced community networks, having our integrated care teams for older person and chronic disease management, we know that there are many people who are on hospital waiting lists who really could be dealt with in community services. And that's a huge part of what we're looking at too. So the longer term solution to all of this is about ensuring that those community lists, and I'm very conscious that we have significant lists in the community that aren't always visible because we don't have the same systems behind them. So there can be a list for somebody going for an assessment, and then they're just put on another list for treatment and so on. So we are capturing all of that as well as part of this longer term work. As I said, in the first instance, it's predominantly trying to get on top of some of the acute specialties, but we do have a different environment, and we are very much looking at how we can actually develop those services in primary care and community services to ensure that we're not putting the same numbers on the list. There are many people going onto hospital outpatient lists who really could be seen in all sorts of different ways in community settings. So I think I'm absolutely in full agreement with that person. We have to change how we do that.
Question about the nursing workforce. Basically, someone saying directly that the level of exhaustion among the nursing workforce and the continued infection and long COVID is just not acknowledged. Why are we still waiting for a funded workforce plan for nurses and midwives? Surely you see nurses resigning with the frustration and the pressure. What can be done to reduce that level of pressure?
Yeah, so I think so we have a funded workforce plan. So I think nurses are huge; they're critical in our system. But we have many people working across our system, and I think for us, we have got, a very clear view in terms of the work that we've done in the last year, 18 months, and very significant levels of recruitment. And we are looking at that in the round. So we have many grades of staff that we are planning for. When you look at our, as I mentioned a minute ago, the enhanced community networks, very significant multidisciplinary inputs to those. And I think lots of grades and specialties, or lots of grades and disciplines, come with their own set of challenges. So we are very committed to working with everybody in terms of looking at how many of everything we need. And as I said, nurses and midwives are key, and we are looking at that. And indeed, we have a very ambitious plan in terms of how we can roll out our winter plan and our service plan for next year.
Just to briefly add what Anne said, we do have a workforce plan. For the first time, it's very significantly funded by government for this year, and because of the impacts on summer recruitment into next year as well, we expect the new National Service Plan. If you just look at since January 2020, we've increased the nursing and midwives professional roles in the health service by just over 3,000. Actual staff nurses and midwives has increased by 1,700. Now, I should say about 10,500 in total workforce increase since January 2020. And that is that's a net increase. So we have to recruit almost 8,000 staff every year just to stand still. But that 10,500 is incremental to our baseline workforce across all the medical nursing professional grades that Anne has outlined. So we do have a plan. It is funded. We've net increased by 3,000 across all nursing midwives professions, 1,700 in nursing. We do want to recruit more. We are in the market to recruit more. We expect to recruit more between now and December. And we expect to have a very well-funded plan for next year, recruitment across all professions as well.
Okay, and Colin, I see someone asking for comment on a statistic that has been reported a lot in the media, which is that it's still very concerning that almost 50% of hospitalizations are unvaccinated people. How come? What age profile are we looking at with these numbers, and can you talk around that?
What the remarkable thing for me is how unvaccinated people are disproportionately represented in hospitalizations. In figures in ITU, I said 69% of one recent snapshot of ITU admissions unvaccinated, and unfortunately those who die. Yes, as the vaccination programme has progressed, we've seen a left shift in the cases. First of all, the overall number of cases, and there are the people, all range of people, those who were tested positive as close contacts, those who had mild symptoms, and those who are severely ill. But what we have seen also is that the translation of those cases into hospitalizations has fallen. It used to be, not so many months ago, that for every 1,000 cases, we saw 30 to 50 people hospitalised and 3 to 5 admitted to ITU. That number has more than halved now. So that we're seeing now, for every 1,000 cases, we find 10 to 15 perhaps hospitalised, and half as many used to go to ITU, now in ITU. So the link in harm between cases and harm has been severely weakened, and that's attributed to the vaccination programme. The question asked is why we will still see breakthrough infection. We did see a tendency as the vaccination programme went down through the ages for some shift in admissions downwards in age, but they tended towards shorter, less sick admissions in comparison to January, February of this year. For those who are most severely ill, we see an increased proportion of unvaccinated people. And for those who are breakthrough, they tend to be older people or immunocompromised or those with underlying conditions.
Okay, thank you. Linda, I have a few more questions in the area of staff health and well-being. So I have been diagnosed with post-COVID syndrome and I'm really struggling. What do I do?
If you're diagnosed with post-COVID syndrome, can I recommend that you get a referral into Occupational Medicine for a review? Some people with post-COVID syndrome are working, others are not working. So even if you're working, please arrange for a referral in. We have additional supports in place that may be able to assist you. For example, we've access to physiotherapy, we've access to care pathways, and we've also got access to a lot of mental health supports in that regard. So that would be my advice.
Okay, and here's a related question. I really need a physiotherapy appointment with a long COVID specialist. The waiting times are really long at the moment. Is that going to improve? Is that going to change?
Yes, and at the moment we are aligning ourselves with the model of care for long COVID, but we do have physiotherapists and we have defined a care pathway for healthcare workers. So again, get in touch with Occupational Health and they will refer you, and this service is free for staff.
Okay, and another question. I'm not sure this is for yourself or for Colin, maybe both of you. I got my vaccines early because of my immunosuppressive condition, but now I'm worried I may not be immune to COVID this winter.
If you're somebody who comes within an immunosuppressed group, the advice is that we give a third vaccine because you won't have achieved the same level of protection with the full vaccine dose. So for those defined members or people who have one of a range of conditions that can lead to a less robust immune response following the initial vaccination 2-dose schedule, the advice now is to get that enhanced third dose to give you the additional protection you need.
Yeah, we're also looking at an antibody test for that particular cohort, so that may be something that we can offer to staff. We're just waiting for confirmation on that.
Okay, thank you. Question about community health networks. I know this is a development within the HSE we're very keen on in relation to primary care. Can someone give us a sense of what progress has been made? Where do we stand now in relation to the development of community health networks?
Yeah, so we're heading towards 97 community health networks, which is our target. I think at the minute we're at 60, 62 or something. And for any of you who are involved in this, you'll know that it has been slow. By virtue of all sorts of things, including COVID. However, we have now achieved a number of our key milestones in terms of the networks, in terms of having network managers, so they are in. We are well advanced in terms of having GP leads involved in networks, and we are looking at an initial, I suppose, level of staffing. So they won't all be staffed 100% from day one, so we're getting to 25% and so on. And I think that, you know, the reality is in the last number of months, we've had very significant progress. Aligned to the health networks, we have our integrated care team, so the specialist teams for older persons, chronic disease management. So we've made very significant progress on those. So I think that, you know, this is a very exciting opportunity. We've had versions of this in the past, anybody who's been around for the primary care strategy, etc. But I think what is different here is that we are really looking at having, I suppose, a real population-orientated approach to the delivery of services. And certainly in recent times, we have made very significant progress, and we are really heading towards our 97 network. So I think it's very much a good news story.
Perhaps you have a very big picture policy question in for somebody, which is about the introduction of a one-tier health service with treatment free at the point of access, the great ambition of healthcare reform. What actions and timeline will govern the introduction of that? Obviously, it's not going to happen next month, but you know, what timeline towards that?
Yeah, I mean, that was the very big ambition from Care to have, you know, full access to hospital care, as you just described. There's a few strands to that that are part of the solution. One is in terms of GP access, and a lot of our new GP engagements and contracts for treating chronic disease, illness, etc., was part of that solution, but increasing our accessibility of care in the community. Issues and discussions that are ongoing at the moment in terms of the negotiations on a new consultants contract is certainly part of that. And we do want to ensure that the public health system is primarily focused on delivering care for public patients, and that is part of it. So big policy issues, they are big issues that have to be worked through with various representative bodies, but it is the right strategic aim of any public health system to have it accessible, and particularly to those in most need. And we do know that it's not just accessibility the issue. There's bigger, wider society barriers in terms of access to healthcare. We know areas of higher social deprivation have barriers to access not just healthcare, but indeed other provisions of like education. So there are big society issues and policy issues for government to break down, and there are specific issues within the health system that we have to work through. But increasingly, these are steps, policy steps for government that we in the HSE are fully open to embrace.
Okay, another of the big policy reform issues I see there, that the new consultant contract. What progress has been achieved on that? Where do we stand in relation to that?
Look, in simple terms, the discussions are still ongoing between the representative bodies, consultants, the IMO and the IHCA primarily, Department of Health officials, ourselves and the HSE. So there's not a whole lot I can say in it right now, just to respect that the negotiations are continuing. It is something we'd like to see brought to conclusion. It's like something we want to see implemented in terms of a new consultants contract. So with respect, I'll let the discussions continue on, but something that we are very anxious to see coming to a successful conclusion.
Okay, thanks. Colin, a question related to something that came up earlier. We're facing into the winter with the Delta variant still circulating. How does that impact on how we will deliver care throughout the winter?
Well, nobody would have wished for winter where we face not just RSV, but influenza, perhaps resurgence of cases and COVID-19. I think trying to be positive with this, and there's a lot to be positive about the vaccination program, the reach of it, the embrace of it, have left us more resilient as a population and with a much greater degree of protection, although not complete. The vaccine, as we know, doesn't afford complete protection, but it affords significant protection against serious illness. Much has been learned, I would have thought, in the past year. As been alluded to earlier, we've built on our acute bed capacity with an aim to create an additional capacity of over 1,100 beds, or I think we're 800 into that at the moment. But more importantly, perhaps, look, for people listening, is to build on these models of care that for too many years we imagined should take place but didn't implement. And these are models of care which allow particularly people who have chronic disease and older people to complete the treatment they need, the assessment they need, in a loop of care that doesn't have to go through a hospital emergency department, it doesn't have to go through a hospital. And the building blocks are being laid. They won't all be ready for this coming winter, but I think certainly we're from implementing these models of care, we're heading towards a more resilient position than we were before. I, of course, have to acknowledge the huge fatigue and exhaustion of staff dealing 18 months of the pandemic going into that. One more thing I'd mention, Mark, is the flu. The flu is a big variable here because we had no cases last year of lab-confirmed influenza, which is remarkable. Now, we know why, because we just weren't interacting enough to get influenza. We're not going to get away that likely this year. We saw great embrace of the flu vaccine among staff last year. I think overall in a hospital setting it was 70% or thereabouts, and in the community perhaps 66%. But there was huge variation. And to talk about some of the positive areas, Our Ladies of Hospital in Drogheda, huge levels of uptake of over 80% of the staff the flu vaccine. Other hospitals, not half that. So I would urge all people listening, please get the flu vaccine. It will make a difference. It will protect you, but it will protect patients and services too. So we have to work on what we can improve, and the vaccine for the COVID has certainly left us safer, but vaccine for influenza and the embracing of that by healthcare staff will also give us an extra margin heading into what could be a difficult winter.
Okay, maybe a question for everyone. I'm conscious we've spent a lot of time talking about both the extraordinary challenges the health services had for the past 21 months and the challenges that are in front of us. So maybe, is there something positive people have noticed from the change, from the relaxation of restrictions to an extent, on a personal level, if you like? What most have you actually enjoyed with the change, or what most are you looking forward to? Any reflections on that?
I'm happy to go first. At a personal level, seeing my granddaughter for the first time in almost 2 years was the highlight, because they live in the United States and it was the first time they could travel and we could see them. So that's made my summer, certainly the back end of the summer. And I think, like many people, my experience was just families meeting up again after so long and talking on FaceTime and talking on WhatsApp. It's just, you can't beat the human touch with your family. So personally, that's been, it's quite inspirational. It gives a whole second wind to go into the winter again for all of us, I think.
Yeah, I think lots of good things happen, Mark. I think for me, it's something about the return to spontaneity. Everything had to be planned and arranged, and now you can actually go out and just go into a coffee shop, or you can go into a restaurant, or you can go into a bar, whatever it is. And I think just that feeling that you're kind of getting back into control of your own life a bit more maybe than we have been, and being able to meet people, I think, in a more informal way is nice.
Just two, from the work point of view, first of all, while of course we're encouraging home working where it can be done, I think, and blending and so on where it can't be done, and for many healthcare workers, working on site is of course essential. But I think meeting people at work and that networking and the ideas that come out of that are something that is much more difficult to achieve on Zoom or Teams. So the ideas bit and the sparks that are generated through meeting people is great. On outside work, being able to cycle to the beach as opposed to a painfully few kilometres short of the beach is the biggest gain for me.
Linda?
I'm going to second Paul's comment. I got my daughter back from Mexico, so that was a great reunion, and I loved having the family over in the garden, and we had a lovely summer.
Very good. Listen, have people any closing thoughts, closing remarks for staff who are out there watching?
Very briefly, from my perspective, we talk a lot about the vaccination program and the success of it and how was it so successful, and being a world leader, being an EU leader and uptake. I think in simple terms, the success of the vaccination program can't be just seen for the vaccination program. The public gained huge trust and confidence in our health service and the people who work in the HSE throughout the past 18 months. And that gave people confidence to go and be vaccinated at a level we've never seen in this country before. So closing remarks from me are thanks for everything that you've done through 4 waves and a cyber attack. Very beneficially for us in the health system. The public have gained a lot of trust and confidence. We know it's volatile, but it's specifically and largely down to your responsiveness, to the trust that people put on yourselves, whether it's frontline support, administration, management, staff, when at the HSE. You've done us proud in that period, and thanks again.
Okay. Anybody else?
I think just from my perspective, it is about, at a very simplistic level, we saw so much innovation. We saw people stepping outside of their, the roles that maybe they had been in, doing things either doing a different role or doing their own role very differently, and being really, I suppose, creative at a time where we really needed people to do that. So for me, it's really about trying to keep hold of that in terms of we want to try and continue that. So in terms of people really being able to step up and do things in a way that makes sense, because I think what COVID taught us is that, often we were able to do things in a way that just made sense for services, made sense for people using services. And certainly I know that from my perspective with the ops team, that is something that we really are looking at as to how we can try and keep it simple to enable you to do what you're doing. I think that's it.
Just briefly, I think back to this room in the first surge when we were operating in such a huge a vacuum of information. And out there in the delivery system, in hospitals, in GP surgeries, everywhere, healthcare workers in Ireland and elsewhere were operating under the most appalling conditions. A new epidemic, a new virus, no protection, no vaccination, and the level of fear must have been huge. And it is just epitomises all that is good with the healthcare profession, is that professionalism, but that courage as well. That at times when other people, when the public at large turned towards them, they were available, they went to work, they had to don and doff the PPE. At that time, they were working without any vaccination in sight. And I think I just want to acknowledge the courage, not just professionalism, of people who were listening and people who aren't listening today for what they did particularly during 2020, when there was so much fear and so much uncertainty.
I've worked in the public sector, I've worked in the private sector, and after a long career in occupational medicine, I always believe that healthcare workers are different. And I think we saw that during the pandemic. And I have been really impressed by people bringing their vocations to the table. I really loved how we all just pulled together. I really loved how we were all working hard and really trying to solve problems, and effectively did solve problems. So I'm very proud of what we've achieved, and I'm very proud of our healthcare workers. I better give a shout out to my team, though. My team have worked very hard, and I have to say I have survived because I've been surrounded by fantastic people working very hard and supporting me as well.
Okay, thank you to Linda, Colm, and Paul. Thank you to all of us for joining us. The best of luck over the coming months, and don't forget the HSE's Health and Wellbeing Unit and Dr. Linda Sisson are here to provide any support you need over the coming period. Thank you very much.